Now to the pharmacology. As a reminder, our goal here is to correct and treat risk factors for heart failure. Hopeful treatment of chronic heart failure is focused around 3 key points, and those are improving hemodynamics, relieving symptoms, and blocking neurohormonal responses. Hint the RAS system. Let's begin with diuretics. We can achieve pulmonary and systemic congestion via sodium and water retention. This is due to an overstimulation of the heart's compensatory mechanisms. The first medication of the loop diuretics is bumetanide. Brand name is Bumex. Furosemide's brand name is Lasix. Torcemide's brand name is Demodex. Loop diuretics' mechanism of action are to inhibit the reabsorption of sodium and chloride in the ascending loop of Henle, and also interfere with chloride binding co-transport system. Furosemide is a potent diuretic that, if given in excessive amounts, can lead to a profound diuresis with water and electrolyte depletion. Therefore, careful medical supervision is required, and a dose-to-dose schedule must be adjusted to the individual patient's needs. For adverse reactions of loop diuretics, these may involve ototoxicity. And ototoxicity refers to a drug or chemical related damage to the inner ear. Such damage can lead to temporary or permanent hearing loss and/or loss of balance. Ototoxicity is more common in an inpatient setting via IV versus ototoxicity in an outpatient setting by mouth. Another one is hypovolemia. This is a decreased volume of circulating blood in the body. Symptoms of hypovolemia may include weakness, fatigue, fainting, and dizziness. Hypokalemia as well, and this is when the blood's potassium levels are too low. Potassium is an important electrolyte for nerve and muscle cell functioning, especially for muscle cells in the heart. Our kidneys control our body's potassium levels, allowing for excess potassium to leave the body through urine or sweat. Nephrotoxicity is one of the most common kidney problems and occurs when our body is exposed to a drug or toxin that causes damage to our kidneys. When kidney damage occurs, we are unable to get rid of excess urine and waste from our body. So our blood electrolytes such as potassium and magnesium will all become elevated. Nephrotoxicity can be a temporary elevation of lab values such as BUN and/or creatinine. And if these levels are elevated, it may be due to a temporary condition such as dehydration, or the patient may be developing renal kidney failure. If the cause of the increased BUN and/or creatinine levels is determined early, permanent kidney problems may be avoided. Cautions to look out for with loop diuretics. First is a US box warning for extreme diuresis. It's important because the patient will begin to deplete water and electrolytes. Although torcemide isn't labeled with a US box warning, it's fair to associate this class with black box warning for diuresis. Loop diuretics will also have a sulfonamide allergy, and hypersensitivity reactions to sulfonamide can be severe and life-threatening. They may include immediate dermatologic reactions such as Stevens-Johnson syndrome. Loop diuretics are labeled as pregnancy category C medications. With all diuretics, we need to monitor electrolytes very closely, especially the serum potassium renal function like BUN and creatinine. The next class of medications are ACE inhibitors, and these all end in PRIL. The ones I have listed up are the medications in this class that have data from large clinical trials, supporting the fact that they improve signs and symptoms of the patient, lower hospitalizations, and prolong the patient's life. This evidence is the reason why ACE inhibitors are utilized as first-line agents for heart failure patients. The mechanism of action for ACE inhibitors is simple. They have an allosteric action on the angiotensin converting enzyme and lowers the production of angiotensin II. The most common adverse effects associated with ACE inhibitors are going to be a strong dry hacking cough. And this is most likely due to the accumulation of bradykinin, which I went over in another video in regards to the RAS pathway. Angioedema is another effect, and this is swelling in the deep layers of the skin. Signs and symptoms that are most common in angioedema are visible in the cheeks and the lips, so generally the face. These areas will become enlarged due to the swelling and will also appear red in the affected areas. Hyperkalemia is termed as high levels of potassium in the blood serum. The normal patient will have a potassium level within 3.5 millimoles per liter to 5 millimoles per liter. Anything above 5.1 should be considered a risk for hyperkalemia, and then the higher the levels, the more severe. We must be very cautious with potassium levels because they may present a patient with no symptoms at all. And in severe cases, this may cause muscle pain, heart palpitations. In worst cases, potassium complications have resulted in cardiac arrest or death. Here's a side note to think about with these agents in heart failure. ACE inhibitors, which have an adverse effect of hyperkalemia, are usually prescribed in heart failure along with loop diuretics. Loop diuretics have an adverse effect of hypokalemia. So we must also advise the patient of hypotension, which is low blood pressure. As a reminder, low blood pressure is anything under 90 systolic and or 60 diastolic. On the flip side, there's hypertension, which is high blood pressure and should be considered when a patient has a consistent reading of above 120 systolic and or 80 diastolic. ACE inhibitors may also cause renal dysfunctions. So when monitoring the patient, they'll normally always get a baseline for each of these: electrolytes, blood pressure, BUN, as well as their serum creatinine. ACE inhibitors have a US box warning for fetal toxicity. This will be termed as Category X. We must discontinue this medication as soon as possible. The class of angiotensin receptor blockers normally end in sartan. Candesartan is the generic for Atacan, losartan is the generic for Cozar, and valsartan is the generic for Diovan. They should be considered in every patient, especially if the patient can't tolerate an ACE inhibitor or has a history of angioedema. The mechanism of action here is simple. They block angiotensin receptors, so ARBs will competitively inhibit the receptor. For adverse effects, we're going to expect the same thing as ACE inhibitors, except we won't have to worry very much about the dry hacking cough. That's normally why they place a patient on an ARB after having no success with an ACE inhibitor. It's also important to note that ARBs do not require renal adjustment while ACE inhibitors do. I made a video strictly on aldosterone receptor antagonists, so please go check that out for the mechanism of action, because I will be flying by this portion. For aldosterone receptor antagonist medications, the brand medication for spironolactone is aldactone, and the brand medication for eplerenone is Inspira. What I want you to remember for the mechanism of action is that angiotensin receptor antagonists will do three things. One is increase the potassium and decrease sodium levels. Two is inhibit the progression of extracellular matrix. And three is help with oxidative stress. For adverse effects, we're going to focus on gynecomastia, hyperkalemia, diarrhea, and orthostatic hypotension. And also don't forget that spironolactone has stronger effects than eplerenone when it comes to sexual dysfunctions. We're going to monitor the same things as we did in the other RAS agents, but I do want to add a few reasons why we should avoid administering this medication. And this will be if the patient has a creatinine clearance under 30 milliliters per minute per 1.73 meters squared, a serum potassium concentration greater than 5.0 milliequivalents per liter, and also avoid if the patient has a history of hyperkalemia. Beta blockers should be considered in patients with previous myocardial infarctions, such as an MI, hypertension, and atrial fibrillation that require ventricular rate control. Bisoprolol is the generic for Zabeta, carvedilol is the generic for Coreg, and metoprolol succinate is the generic for Lopressor or Toprol-XL. The mechanism of action for these beta blockers will be to inhibit beta-1 adrenergic receptors. Carvedilol, however, will also block beta-2 and alpha-1 receptors. Just a quick recall, the heart is loaded with beta-1 receptors, while beta-2 receptors are mainly in the lungs. The very slight advantage that carvedilol might have over the other two medications will be its action on 3 different receptors. The alpha-1 and beta-2 receptors, by the way, account for a large portion of the cardiac receptors. For further information on this, I would suggest checking out the COMET trial, which stands for the carvedilol or metoprolol European trial. Okay, for adverse effects on beta blockers, we can expect to see bradycardia, which is when the patient has a heart rate under 60 beats per minute. A quick note to recall will be that a normal resting heart may be between 60 to 100 beats per minute. Another adverse effect can be hypotension, fatigue, and we're going to take extra caution with asthma patients as it can easily create bronchospasms. Bronchospasms are a sudden constriction of the muscles in the walls of the bronchioles. We must also educate the patient about orthostatic hypotension, which is low blood pressure when going from a sitting position to a standing position. This would be most common in carvedilol. This medication may also worsen heart failure. For beta blockers, we're going to monitor the blood pressure, heart rate, EKG, signs and symptoms of worsening heart failure, and the blood glucose levels. The reason why we monitor the blood glucose levels is because these medications may worsen glucose tolerance. Agents such as carvedilol can prolong insulin-induced hypoglycemia. Since these agents are now going to be working on the heart, that is why they call for an EKG. Major US box warnings to consider in beta blockers, more specifically with metoprolol, is to not discontinue the medication abruptly, because in some cases, patients have experienced a myocardial infarction. One last note for beta blockers is that cardiologists will more than likely start the patient on a low dose and then very slowly up to what the patient may tolerate. For cardiac glycoside digoxin, the brand names are going to be Lanoxin or Digitec. The mechanism of action is going to be the inhibition of the sodium and potassium ATPase pump. This is going to increase intracellular sodium and increase calcium influx. This inhibition of the sodium and potassium ATPase pump leads to positive inotrope effects, which increase in the heart's force of contraction and an increase in cardiac output, generally making the heart pump harder and thus improve cardiac output. One thing to remember is that digoxin only reduces symptoms. It has no mortality benefit by using it chronically, so it's most commonly used in an acute setting. For adverse reactions, just be aware that this medication can cause GI complications such as nausea and vomiting, but a more serious reaction would be digoxin toxicity or digitalis toxicity. For more information on this, I would suggest watching my brief video on chronotropic medications, and then go check out Dr. Paul Boland's video on congestive heart failure medications. Some warnings for digoxin will be digoxin toxicity. The other is also that it has proarrhythmic effects, and this is more common via IV administration. Extravasation is another warning for the inpatient setting. Extravasation is when there is leakage of digoxin or medication intravenously, which potentially can damage the extravascular tissue around the site of infusion. This can cause serious injury such as tissue necrosis. Necrosis is a form of cell injury that can cause premature cell death of healthy tissue. So the next medication I'm going to cover is a venodilator. This is going to be a combination of two drugs, isosorbide dinitrate and hydralazine. The brand name of this medication is known as Bidel. Bidel will have two mechanisms of action. Hydralazine will act as a direct vasodilator of the arteries, and this results in lower systemic resistance. In low doses, venodilators do a great job at dilating the veins by increasing cyclic GMP in vascular smooth muscle cells, resulting in vasodilation and decreased preload. A common adverse effect with this combo medication is dizziness, headaches, and GI distress. We're going to acquire and monitor the patient's blood pressure in three ways: standing, sitting, and supine position, as well as their heart rate. Hydralazine and a nitrate might be reasonable in patients unable to tolerate either an ACE inhibitor or angiotensin receptor blocker because of renal insufficiency or hyperkalemia or possibly hypotension. This next medication is also a combination medication of an angiotensin receptor blocker and NEPRILYSIN inhibitor. The angiotensin receptor blocker is valsartan, and sacubitril will be the NEPRILYSIN inhibitor. These two will make Entresto, which is the brand name of the two generics combined. The combo sacubitril will have two mechanisms of action. Sacubitril is a prodrug that inhibits NEPRILYSIN via the active metabolite LBQ657. This increases the number of natriuretic peptides. Natriuretic peptides play an important role in water and salt homeostasis and in the regulation of our cardiovascular system. The mechanism of action for valsartan is simple: block the angiotensin receptors. A common adverse effect of these two medications are what one would expect from the RAS agents: angioedema, hyperkalemia, hypotension, and renal dysfunctions. Now, when monitoring these patients, we want to achieve a baseline and a continuous status on their serum potassium along with renal function and blood pressure. A major US box warning for pregnancy category X comes on sacubitril. Combo medication has fetal toxicity